All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. These exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
there.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello and welcome. You're listening to the GynoCast. I'm Dr. Eric Heegard.
I'm Twila Dang.
And it's so nice to be here with you again, Twila Dang.
Thank you. It's nice to be here with you, too.
And if you're listening to the GynoCast for the first time, let me just tell you what it is. It's a show that concentrates and focuses on women's health, physical, emotional, psychological, reproductive. What else, Twila?
Everything in between.
Everything in between. We try to talk about things that are oftentimes what people want to hear about, but maybe don't know where to get their answers. And sometimes we talk about topics that aren't really necessarily kind of polite dinner conversation, the spinach dip sort of thing.
Okay, you need to explain the spinach dip sort of thing really quickly, because when somebody's hearing it, they don't have the context.
Well, you're sitting at, okay, so let's say you're at a dinner party, right?
Mm-hmm.
And you're sitting there and you're milling about, you're talking, you're holding your, what drink do you like, Twila?
It doesn't matter.
Okay, it's
alcohol.
I see you as being kind of a...
It's alcohol.
I see you as doing shots.
No.
Like just tons of shit. No, of course not. I see you as kind of a sophisticated Manhattan drinker.
No.
With your...
I'm a whiskey girl.
Okay. All right. Yeah, okay. With your cowboy hat and your belt buckle and just tossing back some
I'm
stuff.
a whiskey girl.
Well, okay, so let me just go with my fantasy, my illusion here.
Okay,
which is you're milling about. Everybody's dressed up nicely.
Yes.
And you've got, I like martinis. I'll just say it. I just like martinis. I like dirty martinis, straight up, 3 olives with blue cheese if possible.
Okay.
And I like them cold as heck, Twila.
Okay.
Cold. Ice crystals.
What does this have to do with the spinach dip
conversation? It has a lot. Okay, but I'm just saying you're milling about, and there are things you're on your mind. Let's say you have some itching and burning down south.
Okay.
Right? And you're not going to just say, be milling, sitting over there near the spinach dip and the carrot sticks, and you're going to mention to your friend, God, I've got this itching, down there.
So in other words,
can you mind hand me the dip? It's just that one of those things. You just, sometimes you just don't know where to go to get the information you want to get, and the place to go is here. You want to go to the GynoCast. And ask your questions, and we will talk about the things that everybody wants to know, but doesn't.
So things that don't come up in polite conversation.
There you go.
Well, there you go.
That's
I'm
right.
all right with that. Well, what are we going to talk about?
I didn't know you were a whiskey girl.
Yeah, I am.
All right. Well, so
it's new.
On that note, please, join our conversation, join our community, and we will generally talk about a different conversation with a different subject with each week, with each podcast. Today we're going to talk about basic infertility.
Okay.
And we're going to go over the basic landscape, evaluation, treatment, causes, risk factors, that sort of thing. And I will tell you that as our podcasts go along, we're going to dive into this more, and we're going to talk about more sophisticated kind of subgroups of infertility as we go along. But
but today was a good chance to
stuff.
Yeah, we're going to give sort of an overall understanding.
That's right.
Okay.
That's right. And infertility, I actually hate the word infertility, Twila.
Really? Why?
Yeah, because very few people are infertile. If you're infertile, that means you cannot get pregnant.
Yes, that's true.
And really most people are what they call subfertile, and which means that their ability to get pregnant is less than what the standard should be.
What the average person, so to speak, is.
So it's just the word infertility.
Well, then why don't we use the word subfertile? Why do we specifically only use the word infertility?
You're going to have to ask God about that. I don't know. I don't know why.
Okay.
But that's the way it is. And so we're just going to go with the convention. So what is the definition of infertility? Well, I think most people think they know what it is. What do you think it is?
The inability to get pregnant.
You got it. You got it. And it's actually a little bit more specific than that. It's the inability to get pregnant after a year of trying with unprotected intercourse.
Okay.
Sexual intercourse.
Okay.
And so, basically that's what it is. If a couple's been trying for a year and they haven't been using birth control, which you'd think would be kind of an obvious part of the definition, and they haven't gotten pregnant, they meet the criteria for infertility.
So does that mean that there are different levels of infertility? Like, is there a difference between, saying, having, attempting for a year through sexual contact to get pregnant and you don't get pregnant versus attempting to use a procedure or something to get pregnant and then you don't get pregnant? Is it all just sort of under the same blanket?
It's all under the same category. And the definition is not completely hard and fast, in that we like to use a year of trying without success as kind of the basic definition, and that works for insurance coverage and actual codes and stuff like that.
Okay, then there's another question. I'm sorry, sometimes you're going to notice I'm going to just jump in and ask you questions while you're trying to get out information, but I can't
even remember what we're talking about now.
Is a lot of, like, the infertility itself, like the words, the terminology that were used, the definitions applied to them, are they actually sort of generated by the medical community or by the insurance industry?
Well, that is a good question, because it's kind of a mixture of both now.
Okay.
And the diagnostic codes for things are very specific, and you would not believe. And I could talk about this you look up a diagnostic code. You can look it up, on a computer, and they will have things like a code for somebody who's got a thorn in their left big toe.
Wow, that's very specific.
Yeah, or somebody who blew off their foot with a cherry bomb. And there's tons, incredibly specific things. It's actually kind of funny in some ways, but the basics is a year of trying to without success. Now we want to have a little bit of some flexibility there, because we want people who, if you're 40 or if you're 35, we generally say 35 or older, and you have been trying for 6 months or more, we want to encourage people to get in and get evaluated, because the ability to get pregnant is very age related.
Well, now you really need to talk about this, because one of the things I was most surprised by when you first introduced this information to me was, in my head, as a middle-aged American woman, I always just assumed that fertility worked a very specific way. And I actually thought it worked more along the lines of how we as a society hit milestones and benchmarks. I thought, you really can get pregnant when you're in your 20s, but you can still totally get pregnant in your 30s when you decide to settle down, and in your 40s it might be a little bit tougher and probably impossible in your 50s. But it's actually much different when you're thinking biologically versus, this is when I want to get a job, this is when I want to get married, this is when I want to settle down. Yeah.
Well, it's interesting because the percentage of couples, let me just throw this out as kind of a basic fact, that about 15% of all couples meet the criteria for infertility. That's a lot of people.
Yeah.
And infertility, the percentage of couples that have struggled with family building has gone up over time. Now, why is that? Is that because people are just, there's something else going on? Well, the real reason is people are delaying childbearing.
Right.
So the average age of a woman getting pregnant now is probably, I'm just going to throw it 5, 6, 7 years later than it was a generation ago.
Right, absolutely.
And there's most things that we can almost treat virtually every kind of infertility, and we're going to go into causes. But the one thing we can't do anything about is age. We're not able to turn back the clock yet.
Okay.
And so let me give you some basic facts.
Absolutely.
Because this is interesting. Because when I'm talking to patients who come in to see me for an infertility evaluation, this is one of the things I start out with. One is, and I know you know the answer to this question, so it takes away the spontaneity.
Okay, go for it.
But just pretend you don't know.
I like looking
pretend
smart.
you don't
go
know.
ahead. Okay.
So what do you think the chance is, and if you're 30 years old, what do you think the chances that you're going to get pregnant every month?
30%.
That's not bad.
So you know the answer to that. But you'd be amazed how people kind of, I think it's because we were told in health class when we were 13 years old that if you have sex, you're going to get pregnant.
Right.
And the reality is we're really not very good at this. We just try a lot. And so, when you're 20 years old, the chance you're going to get pregnant every month is about 30%.
Okay.
That means that, and parents, put your fingers in your adolescent girls' and boys' ears right now. But, you could be having sex twice a day, unprotected sex, and there's a 70% chance you won't get pregnant.
Okay, now
that doesn't give you permission to have wild, crazy, unprotected
please don't.
sex.
I don't want emails. We don't want letters to the show saying my kid heard this and they decided to go try to test the theory and now you're having a grandkid. It's not on us. We're just giving you information.
Yeah.
But then I have a question there. And within that, does that mean that there are people who are infertile, does that mean on the other end of the spectrum that there are people that are just extremely fertile?
I think that's true. And we all know people who just,
I'm raising my hand.
Kaboom. Yeah,
I'm
you're
raising
one of those.
my hand.
So, I think there's variability with anybody. But as a population, when you're about 20 years old, your chance of getting pregnant per month, and they call that fecundity.
That is a very doctory word.
And you got to say it carefully.
Yes, you do.
Yeah, we can't, your fecundity. You got to say that.
Yeah, we're all going to say that time.
Yeah, sober. You better be sober when you say that. So it's about 30% every month.
Okay.
When you're 20. When you're 30, it's about 20%. When you're 40, it's about 10%. So that means if you're doing everything right and you're totally healthy and you're having sex at the right time, if you're 40 years old, about 90% of the time you're not going to get pregnant every month.
And that's at 40.
Yeah.
Okay.
And so, but even at 20, it's not that great. So,
right.
But that's why we give people time. So we generally give people a year to try to get pregnant because generally if you're healthy, your partner's healthy, and there's no other obstacles, most people, 85 to 90% of people will get pregnant within the first year.
Right. Now, this is probably the point where I should tell my...
Are you talking about fecundity again?
No. This should be the part where I tell my lovely $200 fertility doctor visit.
Yeah.
Well,
do it. Do it. I remember that.
When I first got married to my husband, we were newlyweds and we were thinking we wanted to try to get... We weren't trying, but we weren't not trying. And we weren't using protection of any sort, and nothing was happening. And I started to panic. And it hadn't really been that long. I would say probably been like maybe 3 or 4 months. Yeah. But nothing was happening. So I scheduled a visit with a doctor, went to sit down to talk with her, just literally went for an office visit, didn't even go do a checkup. And she started asking me questions, when do you know when you're ovulating? No. She had asked me a couple technical questions about temperature and diet and things like that. And I said, yeah, no, I don't know any of that stuff. And she goes, oh, honey, you're so cute. You're not trying to get pregnant. You're just having a lot of sex with your husband. And that's okay. She said, so go home.
Doesn't it drive you crazy when somebody says you're so cute? That would drive you.
Yeah.
Nobody has ever said that to me, so I don't know what that means.
Well, I mean, at the time, I was
so
just kind of, at the time I felt a little silly. And then she said, listen, here's my advice to you. Go home, get a nice bottle of wine, spend some quality time with your husband, and more than likely it'll happen when it's supposed to happen. So I'm thinking, great, I have insurance. I went to talk to this doctor. We had like a 15-minute conversation in her office. I went home, told my husband, we laughed about it, continued to try, and probably maybe a year later we got pregnant, but when we weren't really thinking about it or trying to prepare for it. I got a $200 bill from her for that 15 minutes of her telling me to buy a bottle of wine and have some fun with my husband. And it was listed as a fertility consultation.
Wow.
So I learned my lesson. Make sure you know things before you ask your doctor. Maybe ask that question during your checkup so you don't get that additional charge.
Yeah, wow. Yeah, that is, that would drive me crazy too.
But it was an important lesson for me in that a lot of us really just think that the mechanics of having a baby are get naked and that's it. Sometimes you do have to, be mindful.
Get naked with a partner.
Well, that would help. Yeah. And I mean, knowing some basic information about yourself and your health and their health and, even knowing when you're ovulating, it's kind of important.
That's right. And so that leads to an important point, which is if, we talk to our patients about this, but I think that we try to encourage couples to get in and speak to their doctor as soon as they start thinking about trying to get pregnant.
So you mean even before you have any trouble, you should go talk to your doctor and say, I think we're ready to start a family.
Right. Okay. Because there's reasons for that. Number one, it allows the conversation. It allows your physician to see if you have any risk factors. Maybe we should just kind of jump into some risk factors for infertility because you can sort of just, and really most of the time you can get a sense of what's going on just by talking to somebody.
Okay, so are these
without
risk
any
factors
expensive tests?
Yeah, are these risk factors common things? Or,
Yeah.
Okay.
Yeah, and so let me jump to, we'll talk about risk factors here a little bit, but I think sometimes it's helpful, and this is a conversation I have with my patients, which is, once I try to set expectations, which is talking about fecundity, Twila. Fecundity.
You're not going to keep saying that word. You're just messing with me now.
I feel like, it's the excitement of dancing around a well, like tiki tembo.
You do realize I'm working the board. I can cut your mind.
Yeah, that I'm dancing around because you just want to make sure.
Did you just say Ricky Tiki? Like that's not
Tiki Tiki Tembo.
It's Ricky Tiki Tembo.
It's not Ricky Tiki. It's not Ricky Tiki. It's Tiki Tiki Tembo.
Is it Ricky Tiki Tembo?
Everybody knows that.
I thought it was.
No,
I don't know.
not.
I'm sorry. Now I'm derailing you because I don't want you to say the word anymore.
I feel like you're dancing around. I'm dancing around the well because it's kind of exciting to think you might fall in. All I'm saying is when you say fecundity, you better be sober and careful.
That's what we're going to name this episode.
All right. Fecundity.
Indeed.
So set expectations, which is tell people, well, at this particular age, this is what your chance of getting pregnant per month is. Because a lot of people feel like, their chance of getting pregnant every month is 90%. Well, it's not. It's what we were talking about before.
Yeah, it's like 30.
And then you want to talk about, trying to kind of feel out whether there's any particular risk factors or issues that could be obstacles. And so I talk to people about, well, what does it take for you to get pregnant? And you said, I think very insightfully, it helps to be naked with a partner who.
Yeah.
But you don't need to be completely naked. We know that.
True.
And actually, maybe you don't even need. Well, you can let your imagination go with that.
Yeah.
But basically, what you need is a woman's got to release an egg from her ovary.
Yes.
That egg's got to go through the fallopian tube into the uterus.
Epic quest.
On the other end of things, there's got to be sperm present at the cervix. Adequate numbers of sperm present at the cervix at the right time. That sperm needs to be able to go through the cervix, which is a maze, an obstacle, and up into the uterus and into the fallopian tube. So, if you kind of break that down, woman needs to ovulate. Mm-hmm. All right. So, we want to find out if she's having a regular period every month because that pretty much is suggestive that she's releasing an egg.
Right.
Number 2, the egg, once it's released, needs to go down the fallopian tube. Is there anything that makes you think that maybe the fallopian tube is injured or blocked? Now, the most common reason for that is an infection, sexually transmitted infections, specifically chlamydia, gonorrhea, pelvic inflammatory disease, but really any pelvic infection can do it.
Okay.
So that's number 2. Could there be an issue with obstructing the egg going on the fallopian tube? At the other end of things, you need to have sperm present at the right time, well, and in adequate numbers. And so, you talk to the man, and is there any? Does the man have any issues getting an erection, ejaculation, that sort of thing?
Right.
Has the man ever had any medical issues that could cause problems with sperm, specifically injuries and infections and that sort of thing?
Okay, so STDs can impact them the same way they impact us.
Absolutely.
Okay.
And then can the sperm get through the cervix? Well, some people can have cervical issues or have had cervical procedures that can cause problems with that. So you ask about that. And once the sperm and egg, once you assume that the sperm can get through the cervix and into the uterus, and the egg is being ovulated and can get through the tube, then you need to know whether there is a hospitable lining that the fertilized egg can implant into.
Okay.
And so those are kind of the basic things. And so it's not terribly complicated. Are you ovulating? Can the egg get through the fallopian tube? Is there normal sperm? Can it get through the cervix? Once fertilization occurs, can it implant? And those are the things we're looking at.
Okay.
And so when so you can, most of the time, you can find that out from a 15-minute conversation with somebody.
Indeed.
And so when we're talking about whether you should go in and see a doctor to get an evaluation for infertility, these are some of the questions that you can ask yourself to see whether you maybe need to go in earlier or whether you can take a little bit more time.
There are certain things you already know from your own health history that could be a red flag. And if you're concerned that it's a red flag,
right, and
you really do want to get pregnant, then you can kind of sort of expedite your process a little bit.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
So these are the things. So, is a woman ovulating? Well, a woman who ovulates has a regular period.
Right.
And so if you don't, and a regular cycle is generally 28 to 35 days apart. From one period to the beginning of another period, 21 to 35 days. So if you have a period every 3 months, don't wait a year to see somebody.
Right. So if you know you have irregular periods for whatever reason, like we know a lot of athletes or people that do a lot of physically intense work can have that be an issue. Sometimes your period is impacted. Sometimes your period is impacted by the type of birth control that you're using.
Exactly.
And that's even a consideration because I know some people that haven't really thought about the fact that they needed to get completely off birth control, like, and that there might be a certain amount of time to be off of it before you can actually start seeing results even. Yeah,
exactly. So, if you don't have regular periods, then get in to see your doctor. Again, at the beginning of our conversation, we were talking about infertility is a year of trying without success. Well, we don't want you, if you never have a period, we don't want you to wait a year before you get evaluated.
Yeah, absolutely.
So, again, we were talking about it's necessary for the egg to go down the fallopian tube. What can obstruct that? Pelvic infection. So, if you have had a horrible pelvic infection, if you had severe pelvic inflammatory disease, if you've had multiple sexually transmitted infections, maybe you shouldn't wait a year before you go in and see your doctor to talk about this.
Yeah, absolutely.
Again, if you, from the other standpoint, male factor, well, if your husband can't get an erection, if he can't ejaculate, if, he's had a horrible trauma to his testicles or his penis or something in the pelvic area, maybe you want to get in and get that evaluated earlier than later, and that sort of thing. So, and the other main thing I want to drive home, because fertility, the American Society of Fertility Medicine, ASRM, is trying to get this information out, which is the importance of age. Now, you said you're 43 years old. You look fabulous. And if you do, I'm just telling you.
Appreciate it.
So if I didn't know you were 43, I'd think you were 30. Right. So,
well, you can say that again all you like.
Well,
and welcome. It's recorded, even better.
Yeah. And so, a lot of people, we are healthier now for most of us than we used to be, and you look great. You can look great at 40 or 45.
Well, we have the sort of the magic that is, things like hair dye and skin treatments, and we all, we're eating differently. What is the thing you hear all the time in the news? Like 30 is the new 20 and 40 is the new 30. So there's even that sort of mental mind trick that you play on yourself, that because you're healthier than the generation before you, or even two generations before you, you assume that if I can still run marathons at 40, I should be able to have kids. Or if I can do bench press 200 pounds at 35, I should be able to have kids with no problem. Like, we just assume we assume all of that stuff is just all interconnected, and it really isn't in that way sometimes.
That's right. And so, a lot of the trouble that people have sometimes is you may look fabulous and be 37 years old, but and you may look 25, but your eggs are 37 years old. The eggs you have as a woman are actually there as a fetus.
Right, we get
so you don't make it like
that is like the punishment of biology. Like
it's not fair.
Listen, we already put us as women through so much, but then we get all the eggs we're going to get at the very beginning.
That's right.
And guys can have babies all the way up until Mick Jagger's what 72, and he just had a baby last year. Yeah. So it's like
it's really not fair.
Good gravy.
There's a lot of things that are not fair in the universe.
Yeah, that's true.
And so age is one of these things where really peak fertility is probably late 20s to 30.
Okay.
And so, once you hit 30, it starts to decline. And we talked about fecundity, the ability to get pregnant every month. It starts to decline gradually. And then once you get into your mid to late 30s, it really starts to go down. So, again, we want you to be cognizant of that and, for your own planning, to get in and talk to your doctor about this. And if you're 37 years old and you haven't been pregnant before, you might want to get in and have the conversation so you can try to find out if there's anything that needs to be looked into more carefully.
Yeah, absolutely.
So when you break down what are the causes of infertility, and you can break it into a third. I'm a lumper, not a splitter.
Okay.
Or maybe I'm a splitter, not a lumper. I don't know. But, about a third of the time, it's due to the guy. So it's almost, it's uniquely the guy. The guy doesn't have enough sperm, or the sperm is abnormal. It doesn't move. And there's whole criteria for that when we do a semen analysis. We look at the count. We look at how they move, the motility, the morphology, how they look.
Okay.
And that sort of thing. But, sometimes they're not producing enough. Sometimes what they produce is not normal. And sometimes they just aren't able to deliver sperm to the right place. And there's a thing called retrograde ejaculation, which can happen from certain neurological issues, which means instead of ejaculating out, which is really what you need to do, right?
Right.
It needs to go out.
Wait, so there's a condition where it doesn't go out, it goes back
into the bladder.
What?
Yeah, and usually that's related to some neurological issues.
Hold on, because I've worked with you for a very long time, and I've never heard that till today. We have done iterations of this format and for a while. I've never actually heard that. You just blew my mind today.
Wow.
And
talk about a spinach dip conversation. It's not like, hey, pass me the spinach dip. Have I told you about retrograde ejaculation?
I'm like,
one of those things.
Wowzers.
Yeah.
That's a learned thing today.
Yeah, so that certain conditions can cause the sperm to go instead of out. Can go back into the bladder, which obviously doesn't help.
I'm going to bookmark that. That's another conversation we're going to have later because I have questions, but I don't want to derail our time.
Well, we're going to this is the thing is that, on the GynoCast, we talk about, women's health, but sometimes women's health crosses into male health.
Yeah,
absolutely. So we're going to talk about, we're going to have shows on that.
Absolutely.
And so about a third of the time it has to do with the man. About a third of the time it is almost completely the woman. About a third of the time, it's either a combination of both or unexplained.
Okay.
And so, you can kind of break that down. If you look at the male factor stuff, and we talked about that, conditions that can cause either abnormal sperm, not enough sperm production, and those are things like, well, there can be genetic abnormalities, chromosomal abnormalities. You can infections, sexually transmitted infections can cause that. The medications and that sort of thing.
Right. Men
are pretty easy in the sense that it's pretty easy to evaluate whether somebody's got a male factor issue, and you just get a semen analysis.
Right.
And that's pretty straightforward. In terms of the female side, the most common reasons are, number one, the woman doesn't ovulate. Number two, there's some sort of obstruction in the egg getting down the fallopian tube. Those are the main ones.
Okay.
And then when you talk about oftentimes couples have more than one thing going on. So you can have a little male factor, you can have some ovulatory dysfunction, and that sort of thing. And by ovulatory dysfunction, I mean they don't release an egg at the same time every month.
Okay.
And so, let me just talk about the basic evaluation. And the first thing is actually what we were just talking about, sitting down and talking to somebody, because basically I can almost, after about 20 minutes of talking to somebody, I can almost always come up with a diagnosis without much more sophisticated testing.
True. And that's because you're an expert and you've been doing this for a long enough time that the patterns, you've seen this, so you can kind of recognize things.
That's right. Now, because simply talking, I'm going to tell a funny story, which, even painful things can sometimes have, funny components to them. So I remember doing a fertility consult on this couple, and I started asking, the classic question, well, have you ever, I say this in about a millisecond, talking to the guy, do you have any trouble with ejaculation? Do you have any trouble maintaining erection? Have you ever had any injury to your kidney, bladder, penis, or testicles? Say that. That's hard to say that fast. Penis, bladder, kidney, and testicles.
Yeah, I'm not trying it.
Yeah. And she just, the wife, and this is, these are tense conversations because usually,
well, they're personal, they're difficult.
Oh my God, there is nothing,
we don't talk to our own partners about some of these things, and then we're in a room with a doctor trying to figure out what's wrong with these things. That's difficult.
That's right, and there's, I remember reading something where they talked about different types of grief, and a couple suffering with infertility, which is often a very silent. People don't talk about it, and so it's isolating. Mm-hmm. But it's up there with divorce and death of a loved one in terms of the intensity of the grieving process. And when people want to get pregnant, it's a pretty basic instinct in many people, the desire to have a family and build a family. And when they can't do it, it is intense.
But sometimes in the midst of intensity, a little comic relief can be helpful. And so she laughs, and she's telling me the story about how, one time they were moving, and her husband was just stuffing all this stuff in a suitcase, and he was wrapping it up with bungee cords and stuff, and one of the bungee cords snapped, whipped around, and hit him in the testicle.
Oh no!
And his testicle swelled up to like a softball size, blue, and she thought it was funny, and he didn't think it was quite as funny, but in retrospect he was. And so I thought, at that point I had it figured out, and there was a testicular injury and that sort of thing. Well, semen analysis, turned out to be normal, but the thing is that you can find things can tip you off.
Right. And, there are things that you find out from just that conversation that will help you, sort of know what direction to walk into.
That's right. And so, what do I do when somebody comes in for a basic infertility evaluation? We talk. We go through we have this huge questionnaire, developed in some ways by the American Society of Reproductive Medicine, and we, I can pretty much tell what's going on oftentimes beforehand. But, the question again is somebody ovulating? Well, sometimes people are using ovulation predictor kits. Mm-hmm. You can get those over the counter.
Are they very accurate?
Yeah, they're pretty good. They can be helpful somewhat. And sometimes people may have heard of basal body temperature charting, which is
I've heard of that.
Where you take basically you're supposed to every morning take your temperature before you get out of bed. So you basically got to have a digital thermal thermometer, which is a very precise thermometer. And before you get out of bed, before you have any coffee, of course, or anything like that, you got to reach over, stick it under your tongue, take the temperature, and write it down. Those were things that were more helpful kind of historically. They're not that helpful because basically you can almost tell if somebody has a regular cycle, mm-hmm. you can almost guarantee they're ovulating. And this is interesting. This is going to be one of the take-home. This is going to be part of your test, Twila, at the end of the day.
Okay.
Because this is another thing that some people don't know, which is when does a woman ovulate? Okay, as compared to their period. Let's just say...
Don't they ovulate? There's a certain number of days before their period that they're ovulating.
Right, exactly. So, because you are a sophisticated women's health consumer now, which is that...
And you told me before.
And yeah, I find this fascinating because most of us, including many doctors, don't realize this. Is we've been told a lot of times in health class that, well, you ovulate on 2 weeks after your period, day 14.
Okay.
Well, in reality, you ovulate 2 weeks, 14 days before your period starts.
Okay. So 14 days before your period starts, you're actually ovulating.
Yeah. And so if you have a 28-day cycle, which is, from the beginning of one period to the beginning of another, mm-hmm. if you subtract 14 days, that is day 14. So you're absolutely right. But if you have a 35-day cycle, which is also considered normal, subtract 14 days, that's day 21. So if you guys are nailing each other around day 14, having intercourse like wild animals, you're going to miss it.
Right, because depending on if it's 28 or 35 days, that's actually going to be a different date.
Exactly.
And
so, let's say your cycle is 21 days apart, which is also considered normal. Mm-hmm. Subtract 14 days from that, that's day 7. It is conceivable you could be having your period and ovulating the same time.
Oh.
And so that's why you got to find out.
You're not getting pregnant there because there's not a lot of us that do that.
Yeah. And so that's why you've got to kind of figure out what the cycle length is so you can figure out if they're having intercourse at the right time.
Right.
So that's not sophisticated, but these are ways of trying to determine whether somebody is ovulating and when they're ovulating. The next question is, are the tubes open? Well, there's tests that we use for that. There's a very simple test called a hysterosalpingogram or a hysterosonogram, and that is a test where we push either dye or saline through the uterus and watch this this contrast or fluid go into the uterus, distend the uterine cavity, and go out the fallopian tubes. It does two things. Number one, it tells us what the uterine cavity looks like, and number two, whether the tubes are open. Very simple test, very well tolerated, not terribly expensive, gives you a huge amount of information. And then we talked about the other main situation is evaluating for male factor, simple semen analysis. Mm-hmm. Then there's other laboratory evaluations that we can do to make sure that the ovaries are functioning okay. And we also want to make sure there's not some other hormonal issue going on, some such as thyroid disease.
I was going to ask you, you're talking about like being hyperthyroid, or any of those kind of conditions that kind of tend to hit us in the middle.
That's right.
Stages.
Exactly. And so you want to make sure you're not missing something stupid.
Okay.
And so, there's some basic lab tests that we make sure that ovaries are working okay and that there's not some other medical issue going on.
Are these kinds of tests and checkups, like if you're doing this kind of testing for infertility, is this multiple days? Is this in one visit? Is this something that takes time to like send out and get results back? Like what kind of?
Well, generally you come in for a basic evaluation, and then we need to decide what tests we're going to do and when they're going to do it. Because you have to do the tests. A lot of the blood tests you have to do like on the third day of your period.
Okay.
The test to look at the fallopian tubes generally is done after your period's done, between days 7 and 10. You want to do it after the period's done, but before a woman ovulates.
Okay, so if you're going into a situation where you're going to be doing some sort of infertility testing, you should mentally prepare that this is going to be, you're starting a process, and that it's not just like one visit will get you some answers, or one visit and a follow-up will get you answers. Like you have to be prepared to know that it's going to take a little time to get to the answers so that you can figure out how to get to solutions.
Exactly.
Okay.
So it's a process, but it doesn't take that long. Usually we can get it done within one cycle or 1 month.
Okay.
And then we can come up with a plan. And the great news about fertility, subfertility, infertility, is that we have excellent treatments. And there's almost nothing we can't work around except for age.
Mm-hmm.
Age, and even that is something that it's not like people just all of a sudden are not able to get pregnant. And it's a spectrum. Some people are more fertile than others at different ages. But when a woman is got ovarian failure, is actually menopausal, when the ovaries are not producing eggs anymore, we can't do anything about that yet.
Right.
We do not have the ability to create stem cells and create new eggs yet. It's going to happen.
Yeah.
And if the guy has no sperm at all, there's really generally not much we can do about that. And so, there are a few things that we can't really correct, although you can work around. And if the man has no sperm, you can do donor. You can get a donor.
There are alternative methods if you get to the point where on either side that you can't produce an egg, they can't produce sperm. Right. So but that's also sort of a conversation and understanding that you're now about to shift how you approached fertility and infertility and what decisions you're going to make as a family, because those are real life decisions to decide. If I can't do this, is this the way that we want to do this? That's right.
So, but for the most part, if you don't ovulate, we can get you to ovulate. If your tubes are obstructed, we can sometimes open them up, or we can just go around them with in vitro fertilization. If there's an issue with the cervix, again, we can move around that. We can do inseminations. We can put sperm directly in the uterus if they can't get through the cervix. Again, if there's a subtle issue with male factor, again, we can get more normal sperm to the place it's supposed to be with an insemination. And if push comes to shove and things are not working with some of the basic techniques, you can move on to in vitro fertilization. And there's very sophisticated techniques that we can move on to that are incredibly successful. Unfortunately, they can be very expensive, and oftentimes insurance doesn't cover it. But
and that'll be something.
Successful.
Yeah, I feel like that's something we should definitely address in the future. The idea of this is when you get into processes like this, these are not just hop in and decide. These are very large, not just lifetime decisions, but these are very large financial decisions that you're going to have to make going into some of these processes.
That's right. So I want to quickly recap some of the things that one of the things we try to do on this show is sometimes we can have very elaborate conversations. We can go here and there and kind of wander around a little bit, but at the end I want to drive home a few points. Number one is that fertility is treatable. Infertility is treatable. There are many good treatments that are highly successful. Number two, it is age-related. Specifically, that's one of the big things. You want to take into account that if you are older, you want to get evaluated sooner than if you are younger. And by older, I mean greater than 35 years old. Mm-hmm. And so generally the definition, if you're otherwise healthy, give it a year. If everything seems normal, and if you're not pregnant, get in to see somebody. But if you're older, don't wait that long. And again, certain things to keep track of. And go back to what we were talking about, which is what do you need to get pregnant? It's not that complicated. You got to release an egg. The egg's got to go through the tube. There's got to be normal sperm. So if one of these things is not normal, get in earlier than later so you're not wasting time. If you never have a period or if you've got wacky periods, you're not ovulating. Get in to see your doctor. If you've had horrible infections or lots of sexually transmitted infections, get in to see your doctor because there may be a tubal issue. And if your husband or partner doesn't ejaculate, can't get an erection, or has had trauma to his pelvis, get in and get it evaluated earlier than later.
Absolutely. Well, I mean, as always, when we're sharing this kind of information, we want to hear from you. If you have questions, if you have comments, if you want to know more, if you want to follow up with this, let us know. Go to Facebook and go type in the search bar, The Gynocast. Just all one word, GYNOCAST. It is a private Facebook group where we extend the conversations that we have here, where we interact with each other, where you're able to get more information and follow-up information about some of the topics that we talk about. All you have to do is request to be a member. We will vet you very quickly, which basically just means we want to make sure you're there for the right reasons, not trying to solicit us, not trying to be inappropriate in the space. We'll accept you, and then you can jump right in. You can send your questions to us through that Facebook page. Hit the send message option, and you can send us a private message. You're also always free to post on the wall any comments that you might have. We have extended conversations that come out of our show topics all of the time, and we want to hear from you. This is a part of the community that we're building, so we want to share this information, but the information sharing is only as good as the ability to get that out and create more conversations.
That's right.
So we hope to have that happen here. So
join our community, be a part of our conversations, cast the net to other people, spread the word.
Spread the word.
Gyno cast the net.
Absolutely, I like that.
What do you think of that?
I like it. It sounds good. And I'll say this, over time, as we sort of get more into these conversations and we're sharing this kind of information, we'll make sure that we provide a space where you can kind of have a bit of a syllabus, where you can get resources that we've talked about here, where we can spell words out like the fancy one you like to say like 15 times today.
Why don't you say it?
I'm not doing it because I'll say it
Careful.
wrong. And
it's like saying, what's the capital of Saskatchewan? Remember what that is? I think it's Saskatchewan. It's Regina. Just say it carefully.
Yeah, so for sure, we're going to make sure that you have resources at your disposal if you want more information, if you want to be able to go a little bit more in depth with some of the things that we talk about. Well, we're going to make sure we get that information into your hands in as many ways as possible. But in the meantime, thank you so much for listening. We're here every week, and we enjoy what we do, so hopefully it's helpful to you as well. So we'll see you next time on the Gynocast.
See ya.